ready to start. So I'm going to start by sharing this screen. And what I've done today is that I'll start by talking about heart attacks and then conclude on what we need to do to prevent the risk of heart attacks. Now, amongst the Black community, the commonest cardiac problems that we envisage are heart attacks and strokes. And strokes are linked to high blood pressure, which also increases the risk of heart attacks that we have, and also atrial fibrillation. Now, we don't have the scope to deal with everything, and maybe one day Charles will invite me to come and give you a talk on high blood pressure, on atrial fibrillation, which are major problems that we have. But today we'll talk about heart attacks. Now, heart attacks are part of a disease complex, which we call ischemic heart disease. And people have symptoms that are called angina. I'm sure most of you have heard of the word angina. And angina, by definition, just describes a pain. So I'm going to now share my, my slides. Let me stop this and stop that. So share my screen. Can you see my screen now?
Yes, we can, Doc.
Okay, so the medical term for heart attacks is myocardial infarctions. And what it entails is blocking of the arteries that supply the heart. So here you have a picture of the heart, and you can see that the heart is supplied as a supply of blood, which comes from either side of, this is your aorta, which is the main pumping chamber, the main vessel of the heart coming out of the heart. So you have got your left coronary artery and your right coronary artery. And this is a schematic representation of what you've seen here. So that's your left coronary artery, and that's your right coronary artery. And they supply blood to the heart. And when one of them gets blocked, then you get what we call a heart attack. So by definition, a heart attack is an occlusion or a blockage of these coronary arteries, which are the main source of blood for the heart muscle. And it initially leads to what we call ischemia. Ischemia is deprivation of the heart muscle of oxygen, and it gets its oxygen from blood. So if it's not getting a blood supply, it does not get oxygen accordingly. And that eventually, if it lasts longer, so normally after about 15 minutes, the heart muscle starts to die. And the longer the blockage remains, the more heart muscle dies off. So that is why when you do have a heart attack, there is a urgency in reopening that vessel. And we'll go to the treatment options that we give. And that's why we say that when you have heart attacks, time is muscle. This is a schematic diagram of what actually happens. So I'll just explain it. This is an arterial wall. Okay, so it has 3 segments. That's not very important, and the names are not important. But this is a patent artery. So it's open here. So it carries blood through to wherever. Okay, this is any artery in the body. It has a similar makeup. Now, often with age and with lifestyle, you get fatty deposits or cholesterol deposits under the wall of what we call the intima. So it's the inner layer of the vessel. And these fatty vessel, fatty deposit, we call it an atherosclerotic plaque. Okay, and normally everybody at a certain stage had some of, small size, or which causes no problems, which we're not aware of. So, by the time you're 50, you will have atherosclerotic plaques. And this could be in your neck, it could be in your legs, or it could be in the heart. So if it's in your legs, it causes what they call peripheral vascular disease. So you get pain when you're walking. If it's in your neck, it can cause transient ischemic attacks or mini strokes, as some people call them. Now, normally, these atherosclerotic plaques, they have a lipid or fat or cholesterol-rich belly, okay? But on top of them, they have what we call a fibrotic ridge. So they're covered, okay? And while they remain like that, either they don't cause any symptoms or they cause angina. So they cause angina because you can see, like, for example, in this illustration, this atherosclerotic plaque has reduced the lumen of the vessel by about half. So that means that when you exercise yourself, or when your body needs more blood supply or more oxygen, it will not be able to receive, so areas of heart muscle beyond that plaque in the vessel will not receive enough blood, and that will manifest as a pain. That pain is called angina, and angina itself can be quite stable. When you have problems is when this fibrotic cap, when it erodes. And when it erodes, it shows the lipid-rich body or belly to the blood, okay? And once that happens, the blood says, something has happened here. I need to plug this hole. So the first way of plugging the hole for the heart, for the body, is to accumulate platelets. And platelets are part of your blood. So your blood is made up of red blood cells, white blood cells, and platelets. And platelets go there to plug the holes. So platelets are part of what stops us bleeding when we cut ourselves. Okay? So if you have a low platelet count, you bleed. Okay? But here, it overreacts. It thinks, oh, I need to plug this, there's a problem. So it starts plugging it, and by getting what we call a white thrombus, because platelets are white, it causes more pain. And then it also activates blood clotting. So on top of the platelets, you get a blood clot. And that blood clot further narrows the lumen, and in some cases, occludes it totally. So when it is occluded totally, that's when you have a heart attack, okay? When you have a partial occlusion, then you get what we call, it's a kind of heart attack, but it's called a non-ST elevation heart attack. So you've got two types of heart attacks: ST elevation, where there's a total occlusion, and non-ST elevation, where you don't have a total occlusion. And what we call by ST elevation are changes that we see on the ECG. So we diagnose that by your ECG. And the treatments are slightly different, and we'll discuss that a bit later. So what are the causes of atherosclerotic disease as a whole and heart attacks? One of the major causes is smoking, diabetes, especially type 2 diabetes, but both types of diabetes, hypertension, and again, hypertension is very prevalent in Blacks, high cholesterol, a family history of premature heart disease, and that is defined as heart disease under the age of 60 in men, and 16 in women, and 65 in men. A sedentary lifestyle of being overweight, male gender increases your risk of coronary disease. Women are protected by their hormones until menopause. And when they reach menopause, they lose that protection, and the risk of heart attacks after menopause increases. Chronic kidney disease, and in some cases, drug abuse. So things like cocaine that can cause constriction of the arteries, which can make the narrowing worse if you already have plaque, coexisting plaque. A cause, though not very common, which is seen frequently, not frequently, it's not common, but it's seen mainly in blacks, is sickle cell disease. So as you know, in sickle cell disease, you have some microthrombosis, and in some cases, there are reports of it causing heart attacks. Okay, so you can have it in young people. Now, why did I choose heart attacks or ischemic heart disease as the cause? Because it causes about a quarter of deaths in the UK. So 27% of all deaths in the UK are from heart and circulatory disease, and that's mainly ischemic heart disease. So you have about 170,000 deaths a year, or just under 500 deaths per day, or one death every 3 minutes come from heart disease. And just under 50,000 of those are people under the age of 75. So it affects young people. And more, we see younger people presenting. And that's because of sedentary lifestyle. That's because of what we eat, cholesterol levels, and that's because of smoking. Okay, and I think it's going to get worse because of sedentary lifestyle. We are now seeing more type 2 diabetes coming at a much younger age. And that is another predisposing factor for heart attacks or ischemic heart disease. Is anything positive? I've been negative so far, haven't I? Well, you can see that we are bringing the rates of heart attacks down, especially if you take the total population. Okay, so the interventions we are doing now by addressing the risk factors is showing its effects, its benefits. So we have less heart attacks than we used to have over the years. And you can see the graph is going down, both in the general populations and in the younger, in the younger age group. Now, this is an American study. I didn't know whether you wanted me to put any graphs. I can assure you it's the only one really that I have that looked at the differences in America between heart attacks in whites and blacks. And that's two different studies, the ARIC study and the REGARD study. And the top line here is the incidence of fatal coronary artery disease. So this is the lighter line is for the whites and the darker line for blacks. And you can see that we have, in America, there's a higher incidence of death amongst blacks when they have heart attacks. And if you look at non-fatal coronary artery heart attacks, funny enough, there's a lower incidence amongst blacks. So we die more, but we have less non-fatal heart attacks. And if you look at the total incidence, it's about the same, slightly less in this study, but this was a younger age group in this study here. So what we see in America is that blacks die more from heart attacks. And when you break it down, it is mainly due to socioeconomic differences. Okay, so access to health insurance, education, income, that's what causes a higher death rate. So when you have a heart attack, how do you present? You present most times with chest pains, but it is possible to have a heart attack without any chest pains, especially in diabetic or the very elderly. They can come with signs with no chest pains. So often they will come with breathlessness. So that's what's called dyspnea. They'll feel tired or fatigued. They will have often what we call sympathetic symptoms. So they'll feel nauseated, they'll be vomiting, they might feel lightheaded, they might sweat. That's just activation of your sympathetic system. That tells you that all is not well. And in some people, they may come in with palpitations, a fast heart rate, because at times heart attacks bring about atrial fibrillation or other rhythm abnormalities, which normally, when it's new, gives a worse outcome. Some people will have symptoms of anxiety, difficulty sleeping. When the ambulance arrives, their blood pressure may be sky high or maybe very low, or they may have a rhythm problem. And normally, let's go back to the chest pain. The classical chest pain that you get when you have a heart attack is what we call angina. And that's a sensation of pressure. So people feel as if someone is squeezing their chest. So the typical the description that they will give you is that someone is holding me in a bear hug and squeezing, or someone is sat on my chest, or I have a pressure on my chest. And surprisingly, some patients do not perceive that as a pain. So when you ask them, do you have any chest pains, they'll tell you no. But if you ask them, do you have pressure in your pain? Yes, they differentiate pressure from pain. So they don't see the pressure as a pain. So it's always important to ask whether it feels like a pressure. Some people will use the word that it's like indigestion, and it's not uncommon. And I mean, I'll give you the story of a very eminent cardiology professor from the Northeast in Newcastle, who it's a few years ago was at a meeting in Spain, and at lunchtime told his colleagues, "Oh, I just have a bit of heartburn, a bit of indigestion." And in the afternoon, he hired a bike from the hotel that the meeting was in, and he was found dead by the roadside. And it was a heart attack he had, and it's very likely that what he felt or thought was indigestion was actually signs of a heart attack. So it's not uncommon for people to present into A&E late because they think it was indigestion, or people come into A&E and we send them home telling them this is not a heart attack, this is indigestion. So if in doubt, get checked out. Women, they have a worse outcome when women have heart attacks, whether black or white. And the reason for it often is that they present with non-classical chest pains. So they describe the pain in a different way that people don't link it, or healthcare professionals do not link it to being of cardiac origin, and at times may dismiss. And that's why at times they present a bit late. And they have a worse outcome often. That may be because they have smaller coronary arteries, but also it may be with the way they present. Because we don't often expect to see it in women, we put a higher level of suspicion when people come in with chest pain when they're women. And at times it is recognized in a belated fashion. So how do we establish the diagnosis? Well, importantly, you have to have some chest pain. So you may have chest pains or some of the other symptoms that you have, but the commonest is chest pains. You will get ECG changes, and ECGs, I mean, I hope I'm not teaching people to suck eggs, is when you put some electrodes across the chest and record it on a piece of paper, that's what is called an ECG. And you can have changes that will suggest an infarct, a heart attack. So if you get ST elevation, so that's part of the ECG rises, then it is seen as it's called what we call an S elevation marker infarction, and that takes normally you are transferred immediately to one of the tertiary centers for what we call a primary PCI, but we'll discuss that a bit later. When you get into hospital, they check your bloods, they look for your cardiac enzymes, and the cardiac enzymes are called troponin, and they are raised. So it's a cardiac enzyme that is found mainly in the heart. So there are not many other things that cause it to rise other than heart damage, although they are. And also you may have a heart scan that will show what we call new regional wall motion abnormalities. So I'll explain this with the next slide. So this is a heart. This is an echocardiogram, okay, that shows a heart. So these are different views. That's one of your valves, your mitral valves. That's the aortic valve and that's the beginning of your aorta, okay? And here, this is the heart muscle on the left, okay? And if you look at your heart muscle, you can see that everywhere around is contracting quite well. So this is normal, okay? This is what normal looks like. And when I say new regional motion abnormality, can you see that this is slightly different? This here does not contract like you saw in the other. This is flat. Okay, I'll show you the other just to turn you into cardiologist overnight. Sorry. Can you see how everywhere thickens well? So that's what we look for. We look for regional wall motion abnormalities. And you can see this here is not moving at all. Okay, so it's not moving at all because the blood supply to this bit of muscle has stopped. Okay, so the wall stops moving, and that's a sign of a heart attack. This does not mean that the wall is the muscle is dead yet. Okay, it may be what we call hibernating or stunned. So when we restore blood supply to this muscle, then it starts functioning normally again. The next treatment when you get into hospital, when you're rushed into hospital, if you have got an S elevation marker infarction and they're applying for a primary PCI, you get what they call an angiogram. So you get catheters that are floated either from your wrist or from your leg, and that's the catheter here, that engage the coronary artery. Can you remember that diagram of the arteries that we started with when I said the coronary arteries? Okay, and you can see how there's a narrowing. Here is quite significant. This is the right coronary artery. It's a significant coronary artery causing the heart attack. Okay, this patient had a heart attack. So you can have also this kind of blockages with angina without a heart attack, but when that fibrous cap is broken off, that becomes a heart attack. And this is an example of the intervention when we say primary PCI. So primary PCI is that you use a balloon to open this up. So this is a narrowing. You inflate a balloon here to open it up, and you put a stent, which is some metal wire mesh to keep it open, okay? And that's the vessel done, seen after an angioplasty and stent. The stent you don't see very well here. The stent is best seen when there's no contrast within the vessel, okay? Please feel free to ask any questions. So we're not going to the treatments. So the treatment that are open or available, if you've got an S elevation myocardial infarction, so when you look at your ECGs, you see that the ST segments have gone up, then you are rushed immediately to a primary PCI center, which in Manchester is either Wythenshawe or the MRI. They take it in turns. And if you are in the Mersey region, it's going to be Liverpool Heart and Chest hospitals that do primary PCI. And what they will do is that they will do an angiogram, which is, should they die down the arteries to see, and where possible, reopen the artery with a stent. Now, it may be at times that for technical reasons, it's not possible to reopen the artery, or that the narrowings are in positions or in places where it is not the best treatment for you. And in that case, you'll be listed for coronary artery bypass surgery, okay? And in some people, we tend to just treat with drugs. We don't neither refer for surgery, because times when the clot has dissolved, the disease that is there does not cause a significant blockage. So we just treat with drugs. So if you've had a heart attack, the drugs that you surely will be on is going to be statins to keep your cholesterol down, because we want your cholesterol quite low. You'll also have, I showed you that first diagram as to how, when the narrowing starts, how you get, first of all, a platelet clog. Now, aspirin is a drug that prevents stickiness of platelets, so that you don't get what we call platelet aggregation. So we use two drugs that affect the stickiness of platelets. One is aspirin, and another is one of these three drugs, either clopidogrel, ticagrelor, or prazosin. And because we know that when we use two drugs for a period of 1 year, we get a much better outcome. Often, you'll also be on a beta blocker to slow your heart rate down, and nitrates. There are other drugs that we can use, and that, depending on patient characteristics, you may be given. Very important when you've had all that is to have what we call cardiac rehab. So people are referred for cardiac rehabilitation, which is a program of exercise and lectures on what to eat, what not to eat, what your drugs are for, but more importantly, exercise. Exercise after heart attacks, or in majority of cardiac conditions, is very good for you, okay, and reduces overall mortality. Any questions so far? No?
Doc, we have lots of questions after your presentation.
After, okay, perfect. So how can we prevent this from happening? And how can we improve our cardiovascular health? And the next few slides affect the entirety of cardiovascular health. So one thing is your diet, okay? So reduce calorie intake, so no excessive calories. We used to say 5 portions of fruit and veg a day. Now people are talking about 10 portions of fruit and veg a day. So we need to eat, fruit and veg must be a major proportion of what's on our plate. Preferably whole grains and high diet fiber, high fiber diets. And if we can consume oily fish about twice a week. Okay, about twice a week. And of course, we limit our saturated fats to about less 7% of the energy that we consume. We choose lean meats, okay, white meat better than red meat, and vegetables as described, skimmed milk, minimize the intake of sugary drinks, and reduce the amount of salt that we do. And I think the reduction of amount of salt is quite important in the Black community, because hypertension or high blood pressure is very common and prevalent, and a driver for a lot of these heart problems that we develop, be it heart failure, be it heart attacks. And not every body responds the same to salt reduction. But we know that Blacks respond more than Caucasians to salt reduction in control of blood pressure. Alcohol in moderation, okay? Now, alcohol is not necessarily bad for the heart. And I'll show you another slide regarding that. Smoking is a no-no, okay? So smoking does a lot of bad things. So you know what, we thought about the atherosclerotic process syndrome, where there's smoking encourages those platelets to stick together, okay? It encourages your blood to be sticky. Part of the lining of, I showed you those three layers of the vessel. The inner layer produces a hormone called nitric oxide. And that nitric oxide causes the vessels to dilate. Smoking prevents that from occurring. So actually, smokers at times can have the opposite reaction. So normally, if you exercise and your heart muscle needs more blood, the vessels produce more nitric oxide and the vessels dilate to allow that flow to go through. By the time in smokers, you get the opposite reaction. So actually, the vessel constricts, which is more likely to cause heart attacks or angina. So again, smoking affects your lipid profile. So if you smoke 20 cigarettes a day, your relative risk of cardiovascular disease increases 2 to 3-fold. So it's something that doesn't, one should definitely not do. Okay. It's not easy to stop, and there are many ways or help that you can get from the community to quit. But the first thing is to want to stop. Okay, a lot of people say, I want to stop, or say they want to stop smoking, but don't really want. But you need to want to stop. I'm not saying it's easy, but you really want to stop. Exercises, as I've mentioned, is very important for cardiovascular health. And what you need for exercise, about 20 to 30 minutes a day of exercise that makes you slightly breathless, okay, and also brings in a bit of sweat on, okay. That's what exercise is. So taking your Chihuahua for a walk is not really exercise. It's a very slow rate. So you need to walk enough to feel slightly breathless at the end, okay. The positive effects of exercise: it improves your blood pressure, it reduces your cholesterol, it reduces what we call insulin resistance. So this is a big factor to heart disease, where you get excess insulin circulating in the body because the insulin receptors are not as receptive to the insulin. So that's, is linked to heart disease. And your biomarkers of inflammation, which is one of the processes that occurs when you have a heart attack, are reduced. Alcohol The new recommendations are 14 units. So no difference between men and women. It used to be 14 for women and 21 for men. It's down also for men. Okay. So alcohol consumption, as far as heart attacks are concerned, okay, so in moderation, if you're not going too high, it actually has a positive effect on reducing your rate of heart attacks by reducing your inflammatory markers and also making your platelets less sticky. But if you drink in excess, you get the opposite, because if you drink in excess, your blood pressure goes up. And that's a factor for heart disease or heart attacks. And also your triglycerides, which are a fat in your bloodstream that has negative effects, also goes up. There are certain factors that we know are associated with heart disease. One is low social support or low social economic input, which is one of the differences that is seen in Blacks in America and accounts for the poorer outcome in care. And that's not just for cardiac health care that is seen. Depression. People with type A personalities have a tendency to have higher coronary events, but it is not, it's a tendency, it's not necessarily, if you're a type A personality and you take care of yourself, it doesn't necessarily increase significantly. Life-changing events can cause a kind of cardiac event called the broken heart syndrome or Takotsubo cardiomyopathy that you might have heard of. And that can be caused by life, sudden stress or bereavement and things like that. And it's due to a sudden release of catecholamines or adrenaline, and so your arteries may be normal, but it still mimics a heart attack. And these are probably one of the hardest things to correct as far as heart disease is concerned, is to kind of correct this socioeconomic disparity that we have in our societies. Thank you very much for listening. I hope you found this useful. And it's impossible, as I said, to discuss every aspect of cardiac problems that affects the Black community, the whole of the community actually. And I think other things that contribute to our ill health, as I said, for Blacks is strokes, which are driven by hypertension in the majority of cases. So we have a lot of problems with hypertension. And as a consequence of hypertension, we have a high rate of or increased rate of heart attacks and also heart failure. But contributory to strokes also is a rhythm abnormality called atrial fibrillation. And atrial fibrillation, the intervention, which is thinning the blood down with anticoagulants, is very easy and would significantly reduce stroke rates if people realize when they had atrial fibrillation to seek health care attention. I think I've done a lot of talking so far. Any questions?
Yeah, we have lots of questions for you, Doc. So if you stop sharing your screen, then we can see loads of questions. But I think the first thing is we'll take up the offer of having you come back, to pick on other subtopics. And then another one that has been suggested is stress and how that impacts on, our heart. And I know you mentioned that earlier on. But then the first question for you is, I've had to have blood tests for my kidney function, and I was told because I'm Black, the readings may be different. Why are the measures different for Black people?
What we measure, so what's different is what we call your EGFR. So you get your, so normally when you do your blood test and look at your kidney functions, you look at your urea levels, your creatinine levels, your potassium levels, your sodium levels. And from that, there's a calculation made to assess your EGFR. And for Blacks, there needs to be a correction. If not, it's worse than it actually is. So there's a correction that you put in your calculation to make it right. So it's not, normally if the form on your blood test says that you are Black, then they should put that correction in the calculation. It's just an equation that they use to calculate.
Thanks, Doc.
It's because that was noted with time that there are differences. So if we use the same level, it seems as if our kidney function is worse than it actually is.
Thanks, Doc. My mom had a stroke a year ago, and she seems to be having some memory loss. Is there a link between vascular dementia and stroke?
Definitely. Definitely. So vascular dementia is often as a consequence of mini strokes. So you have multiple mini strokes in small vessels, and that's why it comes on slowly. You can have, dementia caused by a large stroke, depending on where it affects. So each part of your brain has got specific functions that it does. So if, for example, your stroke affects your frontal lobe, you will have more disinhibition in the way you behave, which maybe becomes a form of dementia to that extent. But the majority of vascular dementia are minor mini strokes affecting the areas of the heart. Yes.
Thanks, Doc. I have heart failure. My skin color has gone very dark. My eyes look quite yellow, and I've lost weight. Are these normal symptoms of heart failure? And can anything be done about that?
Sorry, I don't know where I've gone to. That's, yeah. That's heart failure in itself. I always teach my residents that heart failure is not a disease. It's what we call a syndrome. So it's a signs or symptoms put together that are similar. So the cause of the heart failure can vary from one patient to the other. So the effect is the same. So the heart is failing, but what has caused the heart to fail is variable. It varies. So if I take it one by one, often a sign of the eyes going yellow is a sign of jaundice. So it depends on how yellow it is. So it would be useful to have a liver function test to look at what your bilirubin levels are. It is not uncommon in heart failure for it to affect the liver. So you can get liver congestion because of the backflow of fluid that you get. So that can cause the yellowness in the eyes. To be honest, I can't really account for why the skin is going dark and how dark the skin is going, but the yellowness of the eyes is probably some liver involvement.
Thanks, Doc. So someone is asking, is hereditary high cholesterol condition, does that make you prone to heart issues? And are drinks such as Benecol of any benefit to reducing it to someone with a good diet who exercises a lot and is not overweight?
Well, if you got true hereditary hypercholesterolemia, Benecol will do nothing. Will do absolutely nothing. in true hereditary hypercholesterolemia, your cholesterol levels are quite high. And even using aggressive statin therapy, at times we struggle to get it low. So you need at times more than one or two cholesterol lowering drugs. So if you've got the true genetic hypercholesterolemia, it's unlikely that Benecol will do nothing. So Benecol will reduce lifestyle changes, will reduce, except if your diet is really way out, okay? Lifestyle changes reduces your cholesterol about 10 to 15% only. So if you're starting from a very high level, 10 to 15% doesn't get you to where we want it to be, just with lifestyle changes. So you will need, yes, do everything that you can. So it is lifestyle changes plus Benecol. Benecol studies show about also a 10 to 15% reduction in cholesterol by preventing the absorption. But in hyperlipidemia, it's not a problem of absorption. Don't forget that cholesterol in itself is not a bad thing. Okay, excess cholesterol is a bad thing, but our cell walls is made up of cholesterol. The body manufactures cholesterol. Okay, so part of our makeup is cholesterol. But when that cholesterol becomes excessive, that's when it causes problems. And you can see, if you look at population studies, if you look at what happened to the Japanese, for example, before McDonald invaded Japan, but the Japanese after the war, the rate of heart disease in Japan was very low, very, very low. They had a lot of stomach cancer, but very low heart disease. Whereas when you looked at the Japanese that had emigrated to America, the rate of heart disease was the same as amongst the Americans. And now that the diet and all has changed in Japan, now they have a high rate of heart disease, which they didn't know, 40, 50 years ago. Yeah. But it's the same thing. I trained in University of Ibadan in Nigeria, and when I was training, we didn't see many heart attacks. We saw a lot of strokes, but not many heart attacks. But now the rates of heart attacks are going because our dietary lifestyle is changing.
Thanks, Doc. I'm going to, there's another question here. Can a leaking heart valve be repaired naturally?
No. No, it's a bit harsh. Not every leaking heart valve is a problem. Okay, so as we get older, just like an old vehicle, you leak some oil, so you get some leaking heart valve. So if there are several reasons why your heart valve will leak. One is actually the leaflets. So you remember that. I'll share the slides again if you don't mind. So that's a heart valve here, opening and closing. Can you see that? So that's your mitral valve here. Sorry?
No, you would have to share screen.
Oh, sorry. Can you see that?
It's not up yet.
Is it up?
No, not yet.
Let me go to share screen again.
Yeah.
Okay. So this is the left side of the heart. Okay, that's your left ventricle. And this here is a mitral valve. This is the right side of the heart. And this here is your tricuspid valve. This is another view where we see the mitral valve here, and that's the aortic valve. So you can see there are leaflets. Now, one of the causes of a leaking valve is that there could be an abnormality with these leaflets. Okay, some of these abnormalities are things that we are born with. So at times they are more fleshy and prolonged, and as such have a tendency to what we call prolapse, to fall backwards and allow a leak. At times they get restricted and allow a leak. So there are several reasons. If you have one of those reasons, it will not repair itself. Now, at times, so between here and here is what we call the annulus of the valve, or the mitral valve. So you can imagine that if there was something that caused your left ventricle or your right ventricle to enlarge, okay, that will stretch the valve apart, and that can cause a leak. Okay, now if you correct that, whatever caused the ventricle to enlarge, if you correct it, then your leak might decrease or disappear. Normally it will decrease, it never tends to go 100% from my experience. Does that explain the question?
Yeah, thanks, Doc. I'm going to bring in Dominique.
Hi, Doctor. Thank you for having us today. Very, very interesting and quite eye-opening. At least we're lucky that women do not have any kind of save until they get to the menopause age, which I wasn't aware of, but it still doesn't rule out the fact that we can actually get, if you don't follow the rules. But I have 3 questions. One is, when someone does exercise, you do have sometimes sharp pains on your chest, and I know that could be caused by the heart racing and the extreme, or if you're pushing yourself too much. Could that lead to any issue?
No. So majority of this pain that you get when you exercise, especially in healthy young people, is actually not coming from your heart. It's coming from your musculoskeletal makeup. Now, one thing that people don't realize is that your heart itself does not have pain fibers. Okay, it doesn't have pain fibers. So that is why when people have, again, I forgot to mention this when I was talking about how people present, is that often where you feel your pain has no relationship to where the pain is. Okay, so it is generally across your chest, a tightness. It can radiate towards your jaw or down your arm. That's not where your heart is. That's because your heart has no pain fibers. If I was to take a pin and prick you with your eyes shut, you'll be able to localize to the exact point where the pain is. Now, most of the pain you get when you exercise, that sharp pain, is a very localized pain.
Yes,
you can almost point to it with a finger. Okay, that's very unlike heart pain. Heart pain is a generalized pain. You cannot just say, oh, it's here the size of a 50p coin. That's not heart pain. You cannot pinpoint it that way. So that's the pain you get often when you exercise is not heart pain. It's musculoskeletal in young, healthy people. It's almost like a stitch that's lower down often in your tummy, but it's not. It's got nothing to do with the heart.
Okay, thanks for clarifying that. I have another question. I think I will just put into one. Those that do suffer with anxiety, or someone that do have panic attacks, how could that? Do they have any risk in the future of having any heart attack, or it's completely unrelated?
That's a very difficult question to answer. Now, when you are prone to anxiety, a lot of people who are prone to anxiety hyperventilate. And when you hyperventilate, you blow off your carbon dioxide, okay, and change the ionic nature of your blood, to put it in a simple term, of some of your blood components. And that can cause sensation of tingling. You can get what we call carpopedal spasm when your hand is held in a particular position, but also you get a sensation of chest tightness. So often anxious people will tell you that the chest tightens and they feel the chest tightening. That's directly related to the hyperventilation that they get. And often you can know the difference because you'll either get some tingling around the mouth or some tingling in the fingertips. Not always, but often do. So yes, you can get chest tightness, but that's not related to coronary artery disease. Now, on one of these slides, we said that stress can cause heart disease. That's a very subjective statement, because one thing that you cannot measure is stress. There is no accurate measurement of stress. It's very subjective measuring stress. You cannot take blood tests, because when you're taking your blood test, you're increasing stress levels. And what some people may find as stressful, others don't. And some people may be stressed without any outward expression of stress. So it's difficult to measure stress, okay, apart from some catecholamine measurements that you can make. So what is the exact role of stress? Nobody can tell you. But a lot of people, if you go by questionnaires or lifestyle questionnaires, people will use the word "I am stressed." Is it a subjective expression of the patient, or is it something that is actually measured? So I think, if you don't have any other things like depression or things like that, anxiety per se does not necessarily increase your risk of coronary artery disease. What it does do is increase your risk of having chest pains, which may not be cardiac in origin,
Thank you, Doctor.
Does that answer your question?
Yes, it does. Thanks. Thanks a lot.
Thanks, Doc. There's another one here. So why are Black people more prone to CVD, related conditions at younger ages?
To what?
Why are they more prone to CVD conditions at younger age compared to majority population?
By CVD, you mean cerebrovascular disease?
No, heart-related diseases, cardiovascular.
Cardiovascular disease?
Yes.
Well, it depends on what you call cardiovascular disease. So are Black people more prone to hypertension? Yes. Are young Blacks more prone to strokes? To strokes, yes. To heart attacks, not necessarily more than whites. Okay, so often it is due to blood pressure. So Blacks are very prone to blood pressure problems, at times that are not recognized. So you have more issues with what we call signs of end organ failure or end organ strain in Black hypertensive, because they start getting left ventricular hypertrophy, which is thickening of the heart muscle. They are more prone to kidney disease because of the high blood pressure. And I think a lot of it is because they access medical health late, very often. So yes, I think if you look at, there's not much published from African nations, Black African nations, on myocardial infarctions. but the rate of myocardial infarctions in young people is not excessively high. Actually, in about, was it? If you Google myocardial infarction in young adults, I published something about 10 years ago now, which in very simple terms explains what causes young people to have heart attacks. But it is risk management which is the most important. Risk management. And there was a mention about women having a lower risk of heart attacks. Things are changing. Things are changing because unfortunately now probably more women smoke than men. So because of the lifestyle changes, they're beginning to catch up with men. It's equality. We want equality, don't we?
Okay, Doc. Another question. Obviously, in the times we live in, you know, why do underlying health conditions such as heart failure, you know, creates worse outcomes for those who contract COVID? You know,
why do what?
Why do underlying health conditions such as, you know, heart-related ones create worse outcomes for those who get COVID?
Okay, I thought you were going to ask me why Black people get worse outcomes. That's what's more difficult to answer. It's just that it is an overwhelming viral infection. Okay, and you need your body's full strength. Okay, so it affects everything. So if you see a patient with COVID, the liver function test is off there. You can have direct involvement of the heart called myocarditis. You can get all kinds of problems. It affects everything. And also it's what we realize a bit later on is that it's a condition that causes thrombosis. So it causes little blood clots. And these blood clots at times go to your coronary arteries and cause heart attacks. So that's why the actual cause of death in a lot of COVID patients is cardiovascular. So if your heart is weak from anything, it doesn't take much insult. You know, as I say, it is one more straw that breaks the camel's back. It doesn't take much insult for the heart not to be able to recover itself. So that's why. If you ask me why do Black people, there are many postulations that why it affects Blacks, partly because of the prevalence of comorbidities, but that may not be all. That may not be all. It may have to do with something with the expression of what we call the ACE inhibitor receptor, which may, we have no proof of it, but it may, because there are some studies that suggest that we react differently to drugs, or there were earlier studies, and I think in some areas, or at least American Blacks, has been disproven. So we don't know, but yes, it's because it affects every muscle. You can have direct viral infection of the heart itself. So you can have what we call a COVID myocarditis, and you can have thrombotic events. And don't forget, these people, if you've got underlying heart disease like narrowing of the arteries that I've described, these patients are severely hypoxic. So they come in with very little, very little blood, sorry, very little oxygen in their blood to supply to, I was about to say blood in the oxygen, but oxygen in their blood. So they easily, the heart muscle can become hypoxic. They require very high flow of oxygen to be able to saturate their blood with enough oxygen to go around. So that's why.
Yeah, thanks, Doc. One more question before we wrap up. I mean, you referred to exercise and how important it is, but we've seen some incidents where people who are fit, including sports, personalities, having a heart attack. What could explain that? And I know that there's a project we run called Healthy Hearts, and that was, we went into one of the community settings, and there was a 15-year-old who looked fit, but his heart beating was, a concern to the nurses, and they had to refer to the GP, who then had to put this young man on a 24-hour monitor. So I just want to know why, a fit, sports personality like Fabrice Muamba will have a heart attack on the pitch.
That is, there are a few causes for that, which are slightly different. Now, one of the things that Black people prone to is a condition called hypertrophic cardiomyopathy. Okay, so hypertrophic cardiomyopathy is when your heart muscle thickens, but it doesn't thicken in a smooth way around. So we use the word concentric. It is, you get more thickening towards the base of your heart, or the septum. I can show you where that is if you're interested, again on that slide. And that is a condition that you are prone to sudden death. Okay. Now, the sudden death in these cases has nothing to do, if I'm to come to talk to you in future, I like to introduce the heart or explain that the heart it's like a house. Okay. So if you think of a house has got its mortar and bricks. Okay. That's your heart muscle. Okay. And your valves. That's the mortar and bricks. Your house has got its own plumbing to bring your water in, and that is the equivalent of our coronary arteries. So that today's talk has been about the plumbing of the heart and the problems with the plumbing of the heart. Okay, and a house has got its own electrical system. Just like that, the heart has got its own electrical system. And you can have problems with any of these. So you can have a structural problem of your heart without any problem with your plumbing. Your water works may be fine, or without any problem with your electrics. So you could have individual problems. So you could have a problem with your plumbing, that leaks and affects the structure of the house. So one may affect the other. So that's why if you have a heart attack, like we've been talking about today, you can damage the heart muscles. You can damage the mortar and bricks of the heart, and that causes a new problem, which is heart failure. Now, a lot of these sudden cardiac deaths in young people is actually an electrical problem. Okay, so there's some where it is a purely electrical problem, so they can have conditions such as Brugada or long QT, and in others, it is a condition of the motor and bricks as a muscle, but that has thickened in a chaotic manner that it predisposes to electrical problems. So what makes you collapse all of a sudden in a lot of the Black athletes is unrecognized hypertrophic cardiomyopathy. And that's a genetic condition that you are born with. And depending on the genetic mutation that you have, some are more prone to sudden cardiac death than others. So if you have that, you can get suddenly an electrical rhythm problem. And if you want, I can give you a talk on rhythms at the time, where you just drop dead, or you drop and have what we call a cardiac arrest. Not related to your plumbing. Your arteries are totally normal. Okay, you can, as a consequence of a heart attack, also get an electrical problem that can kill you. Yeah, okay, so they're all interlinked. So you think of your house and these various things. So most of these are things that you are born with. In some people, it's they've got, well, that's rarer, they've got anomalous coronary arteries. So the arteries that we saw on the on that schematic diagram, they take a different abnormal route. Okay, so they come probably, in a lot of them, they come off, rather than having two arteries, all the arteries originate from the same, what we call sinus, the same side, and then take an abnormal route, often between your pulmonary artery and your aorta, and they are prone to compression, and that can cause sudden death. So there are a few reasons why people die. It is in the young people, it is not often that you have a myocardial infarction. If it is compressed, it's actually a myocardial infarction, because that infarcts and that causes the rhythm problem. But there is an interrelation. But the majority of them have a genetic predisposition to rhythm problems.
Thanks, Doc. I'm going to definitely get some dates from you because we need you back. So as you wrap up, there's someone asking, if someone is prescribed a small dose of medication for high blood pressure, could the medication be stopped if this person loses weight?
If the blood pressure is controlled, yes. You know, it is, so if you've got no other problems and you're on treatment for blood pressure, the aim is to treat the blood pressure. So if you lose weight, yes, okay, but you have to be sure that your normal blood pressure is not there just because you're taking the tablets. So you have to monitor. If you decide to stop the medication, then you do have to ensure that it's monitored when you stop, so the blood pressure doesn't rise up again. Yeah, okay, because at times it is just normal because of the medication you're taking. It's not normalized. But yeah, you don't always, if you know, if people who lose significant amount of weight and they are only on a small dose, it's very likely they'll be able to come off. And that is at times should be a driving factor to exercise and watch what they eat and all. So it's possible, yeah, it's possible.
Thanks a lot, Doc. So any final words, enforcing the prevention message, and, we will get further dates from yourself.
Yeah, well, generally for young people, okay, the message I tell them is, and you have to excuse my French here, okay, is when you are eating, when you're choosing your food, normally if it tastes nice, it's bad for you. If it tastes like shit, it's good for you. Or if rabbits eat it, it's good for you. And so, yeah, healthy eating, important. Smoking, there's no role for smoking. There's absolutely no role for smoking. If you want to be healthy, I have young people who come and see me and will tell me, oh, Doc, my father had a heart attack at the age of 50. I'm well, but I want you to do some tests to see whether I have the same predisposition. And the first thing I tell them is, look, come back and see me when you stop smoking. There is no need doing the test when you are harming yourself. So even if I tell you it's okay now, I can't tell you it's going to be okay in the next 3 years. So what's the point? If you really are worried, then take those steps to stop progression, because that's so lifestyle is the most important. It is the lifestyle changes or the management of these risk factors that has led to this reduction in the event of coronary artery disease. Okay, in the what year was it now? In 2019 or so, I went to Finland. There's a part in Finland called North Karelia, and they had the highest incidence of heart disease and heart attacks in Europe at the time. To the point that it is the people from the area who actually went to the government and said, look, you know, we want to stop dying. So they took it upon themselves to change the diet, to stop smoking, and they have significantly reduced the rate of heart disease in North Carolina. That now they are sending people to Scotland to teach us what to do, because our rates are higher than theirs. So a lot of it is just, you know, risk factor modification and lifestyle change. And part of it, I said, exercise. Exercise is very important as part of a lifestyle change. And it's under practice, to put it that word. So, and the thing that if you look at now, at least my observation in the UK, is that you see more people exercising. So you see more people on bikes, you know, which is, but look at the ages. You know, they are the elderly people who have already proven by not having events that they're self-selecting. You don't see that many young people, and that's where we need to start tackle young people, you know, the teenager who is sat in front of his TV and doesn't move out, and is eating crisps and is obese, who, you know, by the age of 15 is diabetic. You know, so we have a time bomb waiting to explode because we're not tackling the right people. You know, we're not forcing these young people to exercise as we. When I was in school, we had PE. Whether you liked it or not, you came out on the field and you exercised. You might grumble, but you'll still do it. So it was either that or the cane.
Great, Doc. We're really grateful. Your presentation was excellent, you know, and really informative. You came down to, you know, our level. You made us cardiologists, you know, you know, in a few hours. Well, not within an hour, but we're really grateful for that. We're going to take up the offer, you know, of bringing you back so that you build on what you've shared. The other thing worth saying is, you know, we're grateful for Ngozi for, you know, inviting you and what we've done with Ngozi and others. Occasionally, there are one or two people who want to have a private one-to-one conversation. And if that's okay with yourself, you know, I will initially get an email sent to you, you know, and then if you're okay with that, it should be entirely, you know, at your convenience. So we're really grateful. And you know, Doc has mentioned about exercising on Tuesday evenings between 6:30 and 7:30. It's our Healthy Heart session focused on exercise and nutrition. And we want to encourage, you know, as many people to join as possible. The flyer is being posted, but you can drop us an email, info@cahn.org.uk, and we'll get you the details. And we're definitely going to have Dr. Osula back, you know, with us. I know someone has posted a message in the chat box. You know, let me just be clear. Our position as CAHN is we value medical professionals. That is why we bring people from our community who have our interest at heart to engage with our communities. We do not have any position against, you know, self-medication and herbal remedies. You know, it's entirely up to you, but we will always encourage people first and foremost to engage with your GP. and that is our position. Engage with your GP, engage with the consultants that we bring on the call, and make sure you make a decision that you are personally liable for. So thanks, Dr. Serge Osufa, for your time. We're really, really grateful for reinforcing, some of those messages around lifestyle, and we'll be delighted to have you back. We're waiting for, your bio and your, photos so that we can celebrate you as we're doing for the other consultants who have freely given time during Black History Month.
Perfect. If you remind me, I'm very forgetful. I'll send one across.
Okay. All right then. So thanks everyone. Enjoy the rest of the weekend. You know where we are, have our website details. Any further questions, please do not hesitate. If there's any topic on your mind, any subject you want us to consider during this health hour, by all means, let us know. On the 24th of October, in 2 weeks' time, we're going to have a dermatologist, coming on, sharing with us. He's one of our own. He lectures at Cambridge University as well. We're also going to have Dr. Joseph Omofuma coming back, looking at some of those mental health issues. And, I'm sure Doc will be back with us, not too long from now, so that he can build on. I like the analogy of the heart as the house and the, electrical and the plumbing stuff. And I'm very keen to learn some more. Thanks, everyone, and take care.
Thank you. Bye.
Okay, bye now.
Bye. Bye.
Bye.
Thank you very much.
Bye.
God bless.